So, Girish, welcome to the platform. And if you start with your case.
Audible?
Yes, we
Am
can.
I audible, sir?
Yeah.
Yes, you are.
Yeah.
Please go on.
Okay. Okay. Sir, is my screen visible?
Yes, yes, very much.
Okay. Thank you. Thank you. Thank you, Maninder sir, for considering me next to the Balwinder sir because of my request to you. So I'm presenting a very short case. This is a neglected case in an adolescent girl. So here I will try to apply all the principle uh, given by Dr. Balwinder sir in my case. So it's a 15. She's a 15-year-old girl. She has a history of trauma due to fall from the stairs 2 months back, and this was the soft tissue on day one. So she came on the day one. She has a poor soft tissue. So we have given the two-stage protocol as Dr. Balwinder sir has explained nicely that you have to give a static environment to the soft tissue for the heel before opening the bony structures. And she was not willing for the two-stage protocol due to the poverty. So the BK below knee slab was applied, and patient went away, and she directly returned 2 months after uh, the injury. So this was the X-ray 2 months after the injury. She had some history of stretching or traction given by some local bone settlers. So this is the picture. 2 months later, soft tissues are completely healed. Young adolescent, 15-year-old girl. So should we start the discussion, or sir, I should proceed what I have done?
So, I think we can take
Yes,
uh,
sir.
opinion from the panelists. And so I'd like to invite Dr. Balwinder first to give his comments on what he would do in such a situation. That it's 2 months down the line from this injury. Patient has not been treated, has been treated in a plaster, and basically you can see that there is a deformity there. So, Dr. Balwinder, what would you like to do in this scenario?
Yeah, so it's a bad situation to be in, obviously. But I would want to define this fracture more clearly, specifically in terms of the articular surface. Obviously, you can see that there is a lot of metaphyseal comminution. The fibula is segmented. There is a deformity in the fibula, and obviously the joint surface, but is not so clearly seen. So what I would do already, this patient has been 2 months down the line. The soft tissues have already settled down. So I would want to look at a CT scan to see the articular surface, how bad it is comminuted. And if we feel that the articular surface is beyond reconstruction, which I suspect, looking at the first X-ray, I suspect it might be really shattered, I would straight away offer a primary fusion for this patient. However, if it is reconstructible, then going by the principles that we just discussed, we can give it a trial of salvage by an open reduction and internal fixation with bone grafting of the metaphyseal defects. Now, where we put the plate and which plate we use in which approach will depend again on the CT scan findings. So if Girish has CT scans, we can take it further.
Girish?
Yes, sir. Sir, we have undergone the CT scans investigations also. So these are the, the 3D CT scan images we have, and these are all the axial images. So there are a lot of anterior comminution, as you rightly mentioned. But the question is salvageable or non-salvageable is again, I need to ask from the other panelist also. And this is a dorsiflexion injury to the anterior pilon, and this is the CT scan images we have.
Yeah.
So may I ask the other panelists, what should be our next thing, like ORIF or fusion? She's a 15-year-old girl with this kind of CT scan, 2 months old neglected injury, untreated.
So Maninder,
Dr. Mahendra, would you like to say anything on that? Would you,
Uh, I think at 2 months, this almost with the intra-articular extension, I would go for a primary fusion.
okay.
Only 15 years girl, so I think we should try to salvage the joint. Yeah, that's my opinion.
Two different opinions. We have other guys. Dr. Rajesh Simon is also here.
I
you
can
there?
butt in. This is Shantanu. Can I butt in?
Yeah, sure, Shantu, please.
Thank you. Thank you. I think this is considering the age of the patient and considering this is only 2 months old and considering that no proper surgery has been done, no proper surgeon has taken care of this. I'll go for reconstruction. I mean, I'll try to do osteosynthesis, try to reconstruct the joint properly by mobilizing the articular surfaces and put in some bone graft in the void thus created. Also, try to take care of the fibular length and then go forward. That is my take on this.
May I ask Dr. Anand sir, so what will be your approach of fixation, your implants of choice, strategy? Let's start with the fibula first.
Yes. Well,
I mean, what things for the fibula?
yeah, the fibular length is of paramount importance, as we all know. So we like to disengage at the whatever fibrous tissue is there. So once we have disengaged the fibrous tissue, and then maybe first of all, but just it is coming to my mind now that we need to have the X-ray and the pictures of the opposite normal side. That will also help us in comparing it with the fracture side. So fibular approach should be the lateral approach, and we should use a plate to regain.
May I?
Yeah.
Yes. So
Correct.
may I ask Dr. Balwinder sir, sir, do you think that doing the fibula first as a universal law, uh, like getting advantage of ligamentotexis is valid in 2 months old neglected fracture when everything is
No,
shattered?
no, I don't think there is any hard and fast rule of which bone should be fixed first in a both bone distal tibia fracture. That is not applicable specifically in this case. Well, in my mind, even if she's 15 years old, I would say that she's already become a lot of stiffness is there. This surface is beyond reconstruction. Looks like that there is a lot of articular comminution and impaction of the cartilage. You can give it a fair trial as best as you can, but she's going to end up with a stiff and painful joint. Even if you are able to give a good X-ray, she's never going to have a good functional range of movement, in my opinion.
Yes.
So in my opinion, I would sit down and have a detailed discussion with this patient. And if if they're not willing for a primary fusion, I will offer them a primary fusion. She's not willing, I will explain that she's going to need a second surgery most probably, and then go ahead and fix it.
All right.
So,
Thank you, sir.
question.
So, yes, sir.
Sorry, just before we move forward, Girish,
Yes.
are you showing your? Okay, so you're showing the fragments.
Yes, sir. So these are the three main questions, sir. So my strategy was I tried the ORIF. I wanted to save the joint. I discussed the thing with the patients, but again, as you have seen that many panelists were not agree for the fusion in a 15-year-old adolescent girl. So I also discussed this thing with the patients, and I went for the option of open adduction and internal fixation with the fair trial of giving a good aligned joint for many years, like for some years when it is surviving. So three questions, the very important, which were in my mind, which I wanted to discuss. One is the comminuted osteoporotic fibula. It is very difficult to put a plate alone. So what should be the fixation strategy, which we have already discussed? Mobilization of the tibial fragments through the approaches, whatever we are taking, it definitely mandates the need of bone grafting, which Anand sir has already mentioned. And these were the soft tissue contractures. If you look at the clinical situation on the table, this were the healed soft tissue scar, transverse scar along the fibula. So my question is, what should be the approach for the tibial and the fibular fractures? So let's start with the fixation because we are running a little late. So I started doing the fibula first, but again, I tried and I learned inside the case that uh, trying the fibula first or the tibial first here doesn't make too much of the difference. So I started with the fibula first, mobilization of the fragment intramedullary cavite to get a length because everything was comminuted. And on the top of that, I tried to put a plate. After that, I went through the extended anteromedial approach, which is a kind of dead anterior approach, but extended in 110 degree towards medially. So these are the healing soft tissue callus which we have seen. Obviously, this was the expected thing because she was 2 months old neglected. So callus mobilization has created a defect, and this was a defect. It was plated with the one medial plate and a anterolateral buttress plate. So this was a situation intraoperatively. There was a question in my mind intraoperatively also that how to buttress the posterior fragment, but I tried to get the indirect reduction and the fixation through the anterolateral plate only because opening the fracture from all the side were not possible. So I took one posterolateral approach for the fibula and one extended anteromedial approach for the tibia only. So this was the closure, and this is the fixation I did. Fortunately, the soft tissue were nicely healed, and this is the 2 months post-op. Talus little in the tilted position, but this is the maximum thing which I could achieve on table. And this is the 8 months post-op with the fairly good range of motion because the dorsiflexion of the distal tibial angle was reasonably okay. So the range of motion was good, and she was walking without any support. Thank you.
I think that's a excellent demonstration of what we can do and try and improve the range of motion. Hopefully, she will maintain that range of motion and gradually get into the fracture. Dr. Balwinder, I like your thoughts on what Girish has done, and Dr. Mahender as well. Both your thoughts on what Dr. Girish has done, and would you have accepted this reduction intra-op?
Well, it's a very good attempt. Obviously, given that she is 15 years old, and that's a good attempt. Obviously, I have already stated that I would have opted for a fusion. So I would stick to that. I mean, you can look at the post-operative X-rays. Somewhere down the line, the fracture is healed, but the joint space looks narrow. She's already had arthritis. She is going to develop an arthritis sooner or later. And but as you said, some days, some years maybe can be had without a fusion. But I suspect how much range of movement and whether she is completely pain free or other things which are to be debated. So, but overall, given the kind of situation that it was in, it's a good attempt at salvage, and if it gives her a few years of painless mobility, then that's good.
So, is there a cutoff point of time where you would say, beyond this time, I will not reconstruct? Dr. Balwinder?
I don't think there is anything which defines that in literature, but 6 weeks is generally considered 6 to 8 weeks in intra-articular fractures if the joint has been subluxated or badly shattered beyond 6 to 8 weeks, the cartilage is already gone. So that is a limit. Then you say that the joint will become arthritic generally, but in Pilon fractures, I don't think there is a hard and fast rule which states that after beyond a certain period of time, you cannot do the reconstruction. But that is overall, in speaking about intra-articular fractures, if a joint has not been reduced for 6 weeks, more than 6 weeks, the articular surface is already gone.
Anybody comments any from anybody else?
Yeah. So Girish, can I make a comment, Girish?
Sure, sir. Sure. Yes, sir.
Yeah, I think Girish, you have done a excellent job of trying to reconstruct the ankle, and the only advantage you have from this point is that if at all you want to go for a fusion, you have got the leg as straight as possible, and probably once you remove the metal work, you can go and fuse it straight away. But here
Yeah.
the patient's counseling is extremely important. I think we need to tell the patients before doing such a wide construction that so many things can go wrong,
Yes.
and primarily at a later stage, you might have to go for a fusion. So counseling the patient here is important. Whatever you have done is absolutely acceptable. And if you want to give a patient, because I have also attempted at 3 months, 4 months, and patient is reasonably happy. But again, at some point of time, the ankle does. But fortunately, a bad looking ankle doesn't function as badly on the X-ray. Even if it looks worse, patient functionally really does pretty well. So I feel that from some reason the ankle does sort of allow a functional range, and even if there is no functional range, patient is quite happy. And at some stage, when the patient does have pain, you can go for a fusion.
Yeah, absolutely, Dr. Mahindra. I think you've hit the nail on the head. Basically, the patient has to be aware of the consequences of what will happen, And there have been studies which showed that up to 6 months also we can reconstruct these fractures with reasonable results. And the patient has to understand that we can do that, but it may not be as the expectations has to be slightly pared down in the case of such a difficult reconstruction. So I think that's great. Anybody else wants to?
So one last point which I want to,
Yeah.
yes, sir.
Yes, Girish, please.
Yes, sir. So one last point which I want to emphasize here is, so whenever we are planning to operate, on an adolescent patient, uh, and we have a set of the implants which are purely made for the adult bone, you may get lot of difficulties. As you can see in my case also, the fibula plate is not perfectly over the fibula, over the lateral surface of the fibula. It is somehow managed to get the maximum length, I mean the maximum possible fixation. If you look at the anterolateral plate and the tip of the anterolateral plate, look at here, it is outside the bone because it is not having a perfect contour. So there is always a mismatch between the available Indian implants and a Pilon, because this is a fourth case which I did on the adolescent patient, and I found the similar difficulties on all the patients, that uh, implants, they are not ideal for the adolescent bone. So you should keep everything ready from 2.7 mm to 3.5 to 4.7, everything on table to get a maximum possible fixation. This is my personal experience.
Yeah, I do agree. I do agree that the implants sometimes do not fit well, and these things do happen. You're right, Girish.
Girish, just for interest, did you use a distractor in your case to distract the joint?
uh, Sir, I kept ready on table, but it was not useful because fracture mobilization, it has already created defect, and that was a part of the surgery. You have to disimpact everything. So fixator here was not very helpful.
All right.
Okay, I think yes, I think that's important really because what and the order of fixation that you mentioned. Anybody would do anything different? Would somebody fix the tibia first in these cases? In these difficult cases, would you want to fix the tibia first, or everybody will go with the fibula first? Any difference of opinion on that scenario at all?
May I add here that, as I had mentioned earlier, that I would fix fibula first here. So I do agree fully, and I maintain the same thing, that there are no hard and fast rule as to, I'll in 100 out of 100 cases I'll fix the fibula first only. Sometime it is tibia first, but in this particular case, I would have fixed the fibula first. Yes.
Okay, great. Yeah, I think we have to mobilize for these malunited sort of picture. We have to mobilize all the fragments and then start fixation. I think that's the key here. Basically, unless you mobilize all the fractures that are already there, you'll not be able to achieve your reduction. Great, thank you, Shantanu. So.